Thank you very much, Kristen. Alan, it's nice to be here. I just came running over. One of my fellows just presented, so I may be a little dyspneic, so please bear with me. So I've been given the nice task of talking about an emerging topic, which is the use of highly sensitive troponin for risk stratification in non-acute patients. And David, one second, let's see. Okay. So David sort of hinted at some of what my topics will be. I'm going to be talking about community-based testing, patients with chronic coronary disease, those with heart failure, and cardiotoxicity. Next slide, please. So let's start first with community-based. Next slide. So given the now availability of assays for troponin that are so highly sensitive that we can detect a somewhat, well, it's not really normal. It's a non-normal distribution of troponins with a measurable concentration and a substantial percentage of patients that are deemed apparently well. We can start looking at links between these troponin assays and underlying cardiovascular risk. Next slide. If you look, for example, at the various population or community-based studies, the Dallas Heart Study, the ARIC Study, Cardiovascular Health Study, and the Framingham Heart Study, depending on baseline cardiovascular risk and the sensitivity of the assay used, a substantial percentage, ranging anywhere from 25 up to 81%, may have measurable troponin concentrations. In our study from the Framingham, we used the single-X troponin I assay, and in this really low to intermediate risk population, it was quite striking that 81% had a value above the limit of quantification. Next slide. If you look at what these values tell us relative to the underlying risk, if you will, of the patients from which they are derived, we see that determinants in this study, for example, from the Dallas Heart Study, which was, a group of patients with only 25% of measurable troponin, even in this population, you can see that these concentrations are reflective of a higher cardiometabolic risk, male sex, minority, age, advanced age, hypertension, diabetes, etc. So there's a clear link between concentrations of highly sensitive troponin and underlying risk when measured in apparently well subjects. Next, please. And indeed, if you look at the links between troponin concentrations and underlying structural heart disease, we see very similar relationships, as in this case, for example, the so-called dose-dependent link between troponin values and left ventricular mass or hypertrophy, as well as coronary calcium, estimated GFR, etc. So it's not just that they are independently associated. There's a direct relationship between the levels of troponins and the severity of the underlying abnormalities that led to their elevation. Next slide. Another interesting link that was recently reported was between concentrations of blood glucose. And this is interesting, and there are data being presented actually literally right now in the room that I just came running from, looking at blood glucose concentrations as an independent predictor of onset of heart failure in population-based studies. And in this analysis from ARIC, as an independent link between hemoglobin A1C and troponin, this persisted even after adjusting for other relevant cardiac risk factors in cardiac structure and function, suggesting underlying cardiac injury related to the milieu of diabetes or impaired glucose tolerance. Next slide. So it should come as no surprise, therefore, that with more prevalent and incident risk factors in patients in the community being linked to the severity of troponin concentrations, we see a significant association between troponin values and the risk for adverse cardiovascular events. These are data for cardiovascular mortality in the Dallas Heart Study, where the fifth category, that being the 99th percentile, was associated with the highest concentrations. Next. These are our data from the Framingham Heart Study. We did not publish the troponin I data in isolation. We actually looked at it together with other biomarkers. But here are the single-X troponin I data in the Framingham, showing the highest quartile out to about 15 years of follow-up had the highest risk for multiple cardiac events, including death in this case, but also heart failure and major cardiovascular disease events. And we exhaustively adjusted for all other confounders to potentially examine whether this link would persist, and it did. Next slide. And interestingly, I have the keys now, huh? There we go, perfect. And it persisted even after we adjusted for other relevant cardiac biomarkers. So these Kaplan-Meier curves or cumulative hazard curves are actually a multi-marker panel together with natriuretic peptides, troponin I, soluble SD2, and GDF15. And each of these markers were independently additive for predicting prognosis in a complementary fashion. It's quite interesting to see that layering these markers did not dilute the prognostic information that each imparted. So this is for death, CVD, as well as and especially heart failure, with a nearly 16% risk by a decade out in the top quartile. So additive value for predicting adverse risk. Now, while one value is useful for predicting hazard, Christy Filippi in the CHS cohort has done a lot of very nice work showing that serial measurements adds incremental value for predicting outcomes. This is an association with cardiovascular death, while this one is with incident heart failure. And the story is the same for both, which is to say that a rising value in red, no matter what your baseline value is, if you're above the 99th and rise, your risk is worse. But even if you're down below the limit of quantification, if there's a rising value seen at subsequent measurement, there's a higher risk for each of these complications. So serial measurements seem to add something relative to our ability to predict risk. And this is also of interest because while we don't yet have much in the way of, and I can jump right to what somebody may get up to the microphone and ask me, which is, what do you do if you have an elevated, highly sensitive troponin in your patient? The simple answer is, I have no idea, other than to risk stratify them the way that we as cardiologists are trained to do. Chris has some nice data that are in press or soon to be published looking at physical activity, actually, in the CHS study, which shows that the more physically active a patient was in the study, the less likely they were to develop a rise in their cardiac troponin concentrations, and they were more likely to show a fall, which suggests, at least in this context, that activity may be in some ways cardioprotective relative to the things that cause troponin to rise. So moving on from community-based subjects, let's talk about heart failure. I will not talk about acutely decompensated failure. As David mentioned, in heart failure, whether acute or chronic, the mechanisms of troponin elevation are legion. There are many. It is not just coronary ischemia, and indeed some of the higher concentrations in chronic heart failure that we see are in non-ischemic patients, identifying underlying cardiac degeneration and processes that we just can't detect with our usual tools to explain why troponin is being released in the hearts of these patients. However, it is not just noise. It is, in fact, a real signal relative to the risk that these patients come into the office with. These are data using the highly sensitive troponin T method in the VALHEF study. Roberto Latini published these seminal data several years ago now, and they've held up over time, which is to say that the higher the highly sensitive troponin concentration measured in a patient with chronic heart failure is, the higher their risk for death or hospitalization. These risks persist even when adjusted for other relevant cardiac biomarkers, and we've looked at in our own cohort a number of different markers, and at least at baseline, troponin is additive to NT-proBNP, it is additive to GDF-15, to soluble ST2, to galectin-3. So the bottom line is that this is a unique pathophysiology beyond that of the other biomarkers that we use. In chronic heart failure, this link between mortality and hospitalization risk is likely reflective of underlying ventricular remodeling and the processes that come along with it, myocardial degeneration and fibrosis with changes in both left ventricular volume as well as ejection fraction. So it identifies a high-risk phenotype. If you look at serial measurements in the VALHEF and GCHF studies, again, Roberto and his group recently published that an increasing value, that's what the I stands for, is associated with higher risk, a stable value is associated with an intermediate risk, and a decreasing value over time was associated with lower risk, whether we talk about all-cause mortality or heart failure mortality. I'd emphasize, however, that the changes in these values were not very significant, and so while a baseline value was quite substantially prognostic, follow-up values added relatively less prognostic information. And again, the reason why we think this is because of the fact that values don't appear to change very much over time. These are serially measured data in patients with chronic heart failure from our own cohort from the MGH, where we have highly sensitive troponin values over time in a cohort of subjects with chronic heart failure due to left ventricular systolic dysfunction. While at each time point there's a significantly higher value for highly sensitive troponin in those suffering from cardiovascular events, if you look at, for example, the baseline and follow-up values in these patients, simply put in a linear regression correlation, we don't see very much change. These are paired samples, so the R value of 0.88 comparing baseline to follow-up implies very little change over time. Nonetheless, when you look at the values of highly sensitive troponin in these patients, they were independently prognostic. Furthermore, as Dr. Gagin and my group has found, and we have these data in press now, increases in troponin concentration are independently linked to some drug therapy changes in this cohort. So it stands to be proven prospectively, but one question could be, if you see a rising troponin value in that small number of patients, about 15% in our cohort, would these patients be eligible for specific drug therapy changes, which is really what we in the biomarker community are sort of driving towards, which is personalizing care based on the individual biomarkers that we measure in these patients. Other potential heart failure applications of highly sensitive troponin in heart failure include monitoring patients with pulmonary hypertension, as well as transplant rejection monitoring. Moving along to another cardiac diagnosis of a stable nature, that being stable chronic coronary disease. Torbjorn Omland showed from the PEACE study that a significant percentage of patients with ambulatory chronic stable CAD have significantly elevated concentrations of highly sensitive troponin, with a large percentage in the very measurable range. And of course, as you can well expect and imagine, those patients with the most elevated values above the 99th percentile had the highest risk for mortality as well as heart failure. Curiously, there was no link with association with new onset myocardial infarction. And this gets back to the predictors of troponin in these patients, which I draw your attention back to that slide that I showed, linking it with LV mass and underlying heart muscle abnormalities. So it's not clear to me whether this is a biomarker necessarily of ischemic risk or a sort of pan-cardiac risk, including heart muscle abnormalities. If you look at patients stabilized 6 months after acute myocardial infarction and examine them relative to their highly sensitive troponin values, those patients with a persistent elevation in the solid line in both panels had a higher risk for mortality as well as future cardiovascular events. So whether measured in just a random fashion or within a period of time after acute myocardial infarction, highly sensitive troponin seem to predict future adverse risk. Now, of course, once again, we really cannot inform a therapeutic decision based on these results. And that's something that is very sorely needed in upcoming trials. Lastly, David made mention in his list of things that may cause troponins to elevate cardiotoxicity. And I'm going to just finish with two slides looking at links between highly sensitive troponin and risk for cardiotoxicity after chemotherapy now, right? So, there are any number of potential areas we can examine relative to the topic of cardiotoxicity, but this is very relevant in the sense that in the United States and worldwide, there are millions of breast cancer survivors with a long-term prognosis that's quite favorable. Yet the therapies that we give to these patients are associated with a significant risk for heart failure, which is amplified with more contemporary chemotherapy agents like trastuzumab. And so understanding which patients are at highest risk for developing left ventricular dysfunction and subsequently tailoring their chemotherapy regimens accordingly, if appropriate, would be desirable. So these are data from our institution looking at a number of different biomarkers and imaging techniques, and the short answer is that of all the markers that we looked at, longitudinal strain on echocardiography, as well as an ultrasensitive troponin method from Siemens, actually, who sponsored the study. It's a pre-commercial assay. Both were strongly predictive of development of LV dysfunction after exposure to chemotherapy agents. And what's most interesting about this is the time course of change, which is to say the troponin values in solid and the echo values in dashed, or in dotted rather, well preceded the changes in LV function over time subsequently. So the take-home message here is as soon as immediately post-treatment, a rise in this ultrasensitive troponin or a change in longitudinal strain, a drop in strain, was associated with future change in left ventricular function, suggesting that we may be able to identify as early as the time of first chemotherapy administration those patients who are likely to develop LV dysfunction and allow us to reactively respond with changes in their chemotherapy approach. So I'm going to wrap up there. We talked about community-based testing, chronic CAD, heart failure, and the potential for cardiotoxicity testing. So I'd like to thank the organizers for inviting me. Thank you.